Recording in progress.
Hello. Am I audible?
Yes.
Good evening, everyone, and welcome. We from the Mission Gastro Hospital are starting the specialty clinics in the gastroenterology from this month, and our aim of this lecture series is to discuss the routine clinical problems and to involve all the other relevant faculties to know the problems faced by the different faculties, and we can find out some solution how to resolve it. So in future also we will going to continue the lecture series with the different specialties, and for this our today's topic of discussion is the gastroparesis, and we have very eminent faculties with us as a panelist. We have Dr. Navneet Shah sir. He is the professor and head of the Department of Endocrinology in the Sterling Hospital, Ahmedabad. We have Dr. Shobna Bhatia ma'am. Ma'am as such doesn't need any introduction. Ma'am is the professor and head and the motility and the GI department at the HM Hospital, Mumbai. And ma'am was the professor and head of the KEM Hospital for a long period of time. And many of the students across the India, including us, have passed from the under the madam. And apart from that, we have Dr. Swati Shah ma'am. She is the head of the nuclear medicine department in Focus Diagnostic, Ahmedabad. We have Dr. Vismit Joshipura sir. He is the senior gastrosurgeon from the Ahmedabad. We have Dr. Hiren Bhatt. He is the consultant endocrinologist at the KD Hospital, Ahmedabad. And Dr. Pratin Bhatt from the Mission Gastro Hospital, Ahmedabad. We from the Mission Gastro Hospital, Dr. Chirag Shah, the director of the Mission Gastro Hospital, consultant gastroenterologist, myself, Dr. Dhaval Gupta, and Dr. Pratin Shah are inviting all of you to join this talk on the gastroparesis. So I invite the Dr. Chirag Shah to deliver his talk on the current knowledge in the gastroparesis diagnosis and treatment.
So, are my slides visible?
Yes.
Thank you, Dr. Dhaval. So, it will be a 20-minute talk followed by discussion by the eminent panel. So, let us start. My talk will be mainly clinical, when to suspect and what are the clinical symptoms which would suggest that we should be thinking about gastroparesis. So we'll start with definition, clinical features, etiopathogenesis, approach to the diagnosis, medical management, surgical management, and nutrition. So what is gastroparesis? So gastroparesis in raw term means that there is paralysis of stomach. So what kind of movements occur in stomach? There is churning of the food and mixing of the food and then pushing the food into small intestine. These are the main movements. So when there is disorder which has symptoms of gastric retention, stomach, the food stays into the stomach, and there is delayed gastric emptying. In absence of mechanical obstruction, this is known as gastroparesis. However, diagnosing gastroparesis is very important because the similar symptoms can also be seen with accelerated gastric emptying and functional dyspepsia also. That is why documentation of delayed gastric emptying is recommended before selecting the therapy with prokinetic agents, and we should not treat anybody as a gastroparesis only with the symptoms. So documentation is very important. What are the clinical features? So main clinical features are abdominal pain, nausea, vomiting, early satiety, weight loss, which is uncommon but can be seen especially in young patients associated with heterogenic idiopathic gastroparesis of very long duration, phytobezoars, and diabetic patients, we can have erratic blood glucose control. So when we have erratic blood glucose control in diabetic patients, you may have to suspect diabetic gastroparesis if the patient has relevant symptoms. What is the kind of pain? So it is localized upper abdominal constant pain, which is like a feeling of a stone being kept in the upper abdomen. This is the typical complaint of these patients, that they feel like a stone is being kept constantly in their upper abdomen. So this is feeling of weight in the upper abdomen all the time. Then what kind of vomiting these patients have? So this is stale food vomiting. So vomiting contains the food which has stayed into the stomach more than 4 hours time. So when you take history, you have to ask for this, that did the vomiting any time contain the food which was eaten more than 4 hours back? If yes, then you have to suspect gastroparesis. This type of symptoms usually occur vomiting occurs usually at night or early morning, and many a times in late evening if the patient has taken a heavy lunch. Early satiety again is a symptom. Weight loss we have discussed. So what are the percentage of symptoms that we have? Nausea is in 93%, abdominal pain, early satiety in almost 90%, vomiting in 70%. So even in absence of vomiting, if there is nausea and persistent abdominal pain with relevant symptoms, you have to think of gastroparesis as a possibility. Nausea, vomiting, early satiety and postprandial fullness correlate better with delayed gastric emptying rather than upper abdominal pain and bloating. And many times these patients are also having history of GERD. So when these patients are having history of GERD, especially for diabetic patients, and this GERD is getting relieved with DSR preparation, domperidone containing preparation, and it is not getting relieved with plain PPI, you have to suspect associated gastroparesis, because this is many a times commonly seen that many diabetic patients are on long-term PPIs with domperidone containing preparation, and they have some associated gastroparesis. Also consider possibility when the symptoms of GERD come back on PPI and they are better on prokinetics. What are the etiology? So etiologies are idiopathic, post-viral, diabetic, post-surgical, neurological diseases like Parkinson, amyloid, some collagen vascular diseases, scleroderma, pseudo-obstruction, and many other causes which can be drug-induced and iatrogenic also. We'll talk about the three most common clinical types. So diabetic gastroparesis usually occurs in patients who have history of diabetes more than 10 years. For type 1 diabetes, the incidence is around 40% in a tertiary care center, but only 5% in community diabetic patients. And for type 2, it is 20% in tertiary care, but only 1% in community diabetes patients. So whenever a patient is being referred to an endocrinologist or a specialist for diabetes care, difficult diabetes control, they are more likely to have this problem because they are referred to a tertiary care center. Medication-induced delay in gastric emptying with narcotics, anticholinergic, and GLP-1 analogs and amylin analogs among the diabetes should also be considered into the possibility. Markedly uncontrolled sugars, more than 200, may also aggravate the symptoms of gastroparesis. This affects the gastric motility and also small bowel motility. And the diabetic gastroparesis also correlates with autonomic derailments in patients who have long-standing diabetes. Many times diabetic gastroparesis also seen in patients who have chronic pancreatitis, and here the contribution of chronic pancreatitis may also be there. So what is the pathogenesis here? Impaired phasic antral contractions, improperly timed pyloric contraction, abnormal postprandial bursts of jejunal contraction, vagal neuropathy, smooth muscle damage, interstitial cells of Cahill damage, and metabolic factors. Why it is important to know the pathogenesis? Because if you know the pathogenesis, you can select proper therapy. So here, if we see all the causes, the only causes that seem correctable to us are first two: impaired phasic antral contraction and improperly timed pyloric contraction. The rest of the things appear difficult to control except metabolic factors, which is control of diabetes. Okay. What is idiopathic gastroparesis? So it usually occurs in young or middle-aged women, usually insidious onset. In 1/4, it is acute onset, but usually a good prognosis. And what these patients typically have a history of post-infection, some infection. So if you ask history, they'll be able to tell you the exact onset, that in 6 months I had diarrhea and vomiting, and after that I started the symptoms. So that is usually post-infectious gastroparesis, and these patients respond well. This is usually short-lasting. Commonly seen with norovirus, Lyme disease, many a times seen also after vaccination of tetanus and anthrax. Overlap with functional dyspepsia and depression is common, and these patients are more likely to have nausea. Patients with idiopathic gastroparesis have more early satiety, while diabetic gastroparesis patients have more severe retching. in idiopathic gastroparesis, loss of interstitial cells of Cahal, inflammatory mechanisms and vagal neuropathy are common causes. Many times isolated gastric myopathy can be the cause, and many causes of this are partially reversible on themselves. That is why this is usually short lasting. Post-surgical gastroparesis, it is usually after surgery which can damage the vagus nerve. So vagotomy and drainage, highly selective. Vagotomy, Roux-en-Y gastrogynostomy, Whipple's, gastric bypass, pyloroplasty, fundoplication, esophagectomy with gastric pull-through. All these surgeries can lead to post-surgical gastroparesis. Post-viral, as we have discussed, it can also be caused by cytomegalovirus, Epstein-Barr virus, and varicella zoster. The post-viral gastroparesis can be with or without autonomic neuropathy. If there is autonomic neuropathy associated, these patients are likely to have bad prognosis, and it will usually recur very late, or it will not recur at all. Which are the drugs causing delayed gastric emptying? Morphine, oxycodone, tapentadol, exatinide, cyclosporine, calcium channel blockers, many times some antacids, sucralfate, aluminum containing antacid syrups. There is a huge list, but these are the common agents which cause delayed gastric emptying, and we have to keep those in mind. Which are the disorders of isolated gastric motor dysfunction which can mimic gastroparesis? So here we have a list of conditions which would mimic like delayed gastric emptying, but it is not true gastroparesis, and we have to know that the interventions for gastroparesis will not work here. Like the isolated gastric motor dysfunction associated with radiation, malignancies, median arcuate ligament, atrophic gastritis, ischemic gastroparesis, scleroderma, Chagas disease. These patients are less likely to respond because this is a neurological disorder and less likely to respond to the primary therapy, which are surgical or endoscopic therapy, and medical therapy, which is targeted towards the pyloric muscle dysfunction. So, apart from the neurological disorder, there are certain disorders which are differential diagnosis, like cyclical vomiting syndrome, migraine headaches, and high cervical injury and peripheral nerve disorders. Here also we have to keep this in differential because this patient will not respond to standard therapy. How do we make diagnosis? Based on scintigraphy and carbon-13 breath testing and endoscopy. If there is delayed gastric emptying on endoscopy after 12-hour fasting, it is confirmatory. So these three tests which are marked in bold are approved by ESNM UEG for the diagnosis of gastroparesis. Wireless capsule motility testing and gastric ultrasound is not approved. How is the gastric scintigraphy done? We have to stop the medicines before doing the test 48 to 72 hours prior. Pre-test blood sugar should be less than 275 and it should be more than 40. 4 to 6 hours of fasting is required. In premenopausal woman, it should be done in first 10 days of the menses. Patient should finish at least 50% of meal during the test in 10 minutes, and patient is given half dose of insulin of his regular dose before the test if this patient is on insulin therapy. Which medicines are to be stopped? Metoclopramide, etopride, cinetabrid, levosulfide, domperidone to be stopped before 3 days. Codeine, morphine, oxycodone for 2 days. Dicyclomine, hyoscine, glycopyrrolate, antidepressant, calcium channel blocker, gastric acid suppression, aluminum containing antacid, all before 48 to 72 hours. Laxative should not be taken previous night. Atropine, nifedipine, progesterone, octreotide, theophylline, and benzodiazepine for 2 days. If the patient has nausea, ondansetron can be given. This is how the test should be done. Then only you can rely on the test. These are the normal gastric emptying curve for liquid and solid. Dr. Swati madam will tell us how to interpret this, so I am not going on this right now. The sensitivity and specificity of this test at various values, like if it is more than 60% retention at 2 hours, the test is 100% sensitive and only 20% specificity. However, if it is if we see at 4 hours, the sensitivity 100% and specificity increases. And if we see at 1 hour, of gastric retention less than 30%, then sensitivity is 90%, specificity is 100%, 90%. So we have to see all the three figures into the result. Wireless motility capsule, it is a specialized capsule which is used to check the gastric emptying time. 5-hour gastric retention time of this capsule has a sensitivity of 83%. However, this is not used practically, being very costly. I'll talk in short about two specialized tests which are done for the treatment assessment, not for the diagnosis. One being EGG, which is recently supposed to be used for choosing patients for pyloric therapy. So those patients who have bradygastria, low amplitude gastric wave patterns during the postprandial phase, these patients are less likely to respond to pyloric dilatation therapy. And those patients who have tachygastria, they are thought to believe some kind of pyloric obstruction. And that is why this tachygastria is there. So these patients are more likely to respond to pylorus targeted therapies. The another method is endoflip, where there is a balloon which is inflated at the level of pylorus and you can measure the pyloric distensibility. And based on that, you can take a decision whether this patient will respond to pyloric dilatation or GPOM or pyloromyotomy or not. And this pressure of this pyloric sphincter also goes down after the surgery. So you can assess the response also. So in treatment, what do we have? So in treatment, we have nutrition, which will work for all categories of patient, but the small particle size food and in small quantities, many times not practical to continue for a very long time. And on long term, it can lead to malnutrition, protein calorie malnutrition, and micronutrient deficiency. That is why nutrition therapy, though it is important along with the primary therapy, it is not the primary mainstay of the gastroparesis treatment. And the primary mainstay being medical therapy. So what do we give in medical therapy? PPI. Almost 70% of these patients receive PPI, and of these almost 50% have GERD coexistence. So we don't know whether this PPI is really helping gastroparesis. The data suggests that the PPI alone are not useful for treatment of gastroparesis. They improve symptom in only those patients who have associated GERD. Metoclopramide is approved in US for gastroparesis, but the problem is that more than 12-week use has an extrapyramidal side effect, and which many times can be irreversible. Domperidone is safe for long-term use. The usually prescribed dose of 30 to 80 milligram, which is a usual dose prescribed for gastroparesis, it causes prolongation of QTC interval. However, this prolongation of QTC interval is significant in only 6% patients to be clinically significant and be worrisome. But we have to be extremely careful if in these patients we are giving any other medicine which can prolong QTC interval. Many a times these patients also receive some antidepressants or some antibiotics. At that time, if you don't adjust the dose of domperidone in gastroparesis patient, it can lead to sudden cardiac arrhythmia and death. Aprepitant is useful for severe nausea. However, it is not recommended for routine long-term management. Levosulfide is effective, but again, same with metoclopramide, extrapyramidal side effect on long-term use and hormonal disturbances in young patient precludes its long-term use. So of this, I think safest drug which we have is domperidone, but that also requires monitoring of QTC interval, especially more precautions with the co-prescription drugs. Prucalopride, 5-HT4 agonist, is approved for gastroparesis, and erythromycin is effective, but on long term, it has issue of antibiotic resistance. So it's not a preferred drug for long-term use as it is usually required in gastroparesis. Which are the drugs which are not effective? So ondansetron, ganisetron, etopride, amitriptyline, escitalopram, busporan, and mirtazapine are not effective. Gastric electrical stimulation. It is a device which is placed on the stomach and generates new electrical waves inside the stomach, and this is used for treatment. However, the results are variable, so we'll discuss that in the panel discussion. The botulinum toxin, again, short-term effect, lasts for 6 months in 50% of patients. However, you can know which patient is going to respond GPOM with this But the problem of injecting botulinum is when at the time of GPOM, you will have fibrosis. So that makes the procedure difficult. GPOM overall response 50 to 60%. It is a similar surgery, endoscopic surgery like POM surgery for achalasia cardia. You make a submucosal tunnel and then cut the muscle submucosally from pylorus towards the proximal stomach. Surgery. Various kind of surgeries have been performed like near total gastrectomy and Roux-en-Y reconstruction with and complete gastrectomy. The symptomatic improvement is seen in 43 to 90% of patients, but morbidity is also seen in up to 40% of patients. So what is the final treatment algorithm? As per the UEG ESNM consensus, they agree on the etiology and the diagnostic method. However, on treatment, everybody agrees that the diet is the mainstay of treatment, which will be helpful in everybody. The PPIs, we are not sure. Antiemetic on D2 antagonists and 5-HT4 antagonists are the only main two drugs on which everybody agrees that they are helpful. The gastric electrical stimulation, pyloric Botox injection, pyloric endoscopic myostomy and gastrectomy have variable results. So the patient selection for this therapy becomes very important. The hypnotherapy, CBT and acupuncture have no role. Nutritional support needs to be continued for most patients. Thank you. With all this, I think we have laid a good platform to discuss gastroparesis management in a multidisciplinary team. So we'll look forward to the panel discussion now.
Thank you, Dr. Chirag, for this informative and very concise talk on gastroparesis. So now I would like to open the forum for the discussion, for the panel discussion. Before proceeding for the panel discussion, I would like to inform our audience that we have also kept one short quiz, a 5-minute quiz at the end of the discussion. It will be on the kahoot.in, kahoot.it. It will be available on the Google, or you can download the app also. And winner will be given this book of clinical gastroenterology by the Rajiv Mehta. So now I would like to open the discussion. I would like to ask Dr. Navneet Shah, sir, that how often do you find the gastroparesis in your diabetic patients, and what is the exact prevalence you find in routine clinical practice, and is there any difference in the prevalence of gastroparesis based on the type of diabetes and duration of it?
If you thank you, Dhaval. First of all, let me congratulate Chirag. He had a wonderful discussion, wonderful presentation, and probably there are no questions after his presentation. If there are only questions, then it is probably we have not attended his lecture in focusing his talk. So now when you say gastroparesis, it is very difficult diagnosis, and most of the time it is presumptive that this is the gastroparesis or this could be gastroparesis. Very rarely you need investigations to confirm the diagnosis. As a clinician, as a diabetologist, I would say we hardly, except for upper GI endoscopy, which usually like to rule out Gerd or the candidiasis, these are very common associated features with this kind of patient. So if you look at the population studies, the incidence of gastroparesis is around 10 to 20% in diabetic population. But those patients who have symptoms like Chirag mentioned, that nausea, vomiting, abdominal fullness, bloating, and postprandial fullness, and all those things, and weight loss occasionally, then there is a chance that 50 to 65% of the diabetic patients with complaints will have gastroparesis. But in type 1 diabetes, in tertiary care, it is 5%, and in type 2 diabetes, it is 1% where we find the gastroparesis. So in clinical practice, to be very honest with you, most of the time the treatment is so symptomatic, and many of the patients would be on prokinetic plus proton pump inhibitors, and 90% of these patients will have relief of their symptoms related to gastroparesis.
Okay.
Dhaval.
Thank you, sir. And sir, what should be the target of glycemic control in such diabetic
Yeah, good
patients?
glycemic control gives you a benefit because acute hyperglycemia itself is one of the precipitating factor for gastroparesis. So you should avoid the swings and the glycemic variability. And chronic hyperglycemia also is associated with autonomic neuropathy, which involves the myelintic plexus and involving the esophagus and the stomach. So good glycemic control in form of A1C targeted 6.5 to 7, depending upon the duration of diabetes, type of the diabetes, would be a good target for controlling the diabetes.
Do you see patients with autonomic disturbances and diabetic gastroparesis together?
To be very honest with you, autonomic neuropathy, usually they have tachycardia, postural hypotension, which is very commonly presenting features with sexual dysfunctions like impotence and all that. But in this subset of patients having autonomic neuropathy characterized by severe postural hypotension, they do not have really a gastroparesis symptom. So it is, I can't say that both the things go together.
Is the duration of diabetes has any relation with occurrence of gastroparesis so that we can suspect in our patients before surgery?
Yeah, duration more than 10 years is usually is associated with gastroparesis. So long duration, uncontrolled diabetes, two things, and then presence of other comorbid or the other complications related to diabetes. Like if you have neuropathy, nephropathy, microangiopathy, then it is very likely that you may have diabetic gastroparesis.
Thank you.
Thank you, sir. Now, I would like to ask Dr. Sobna ma'am. Ma'am, what is the role of Electro Gastrography and Andropylomanometry in practice in gastroparesis?
So, first of all, thank you, Dhaval, and thank you, Chirag, for having this session. And congratulations, Chirag, on the lovely talk. Second thing, Dhaval, can you put your slides on slideshow? Sorry.
Yes, ma'am.
I mean, once a teacher, always a critic is what I would say.
Yes,
so first thing is that as far as electrogastrography is concerned, it is an upcoming technology in India. There are some people who are monitoring it. Many years ago, we had tried to do it, but were unsuccessful because the probe invariably also measures cardiac activity. And sometimes there can be interference with that. But yes, science, what we have learned so far is that the slow waves are associated with nausea. And what we also know that the one single symptom that differentiates gastroparesis from functional dyspepsia, even if a functional dyspepsia patient has mild delay in gastric emptying, the only symptoms that differentiate the two are nausea and nothing else. Vomiting can occur in functional dyspepsia. When we talk of stale food vomiting, that too is sometimes possible if patient is on cannabinoids and opiates. But nausea is a very specific symptom, so we have to look for that. The second thing that you asked is about andropylomanometry. This is a very, very useful test. There are very few centers in India who are doing it, but the usefulness of antroduodenal manometry is a little more for classifying the types of pseudo-obstruction that you see. And this is especially in children. Even in adults, it's useful. So if a patient comes with severe nausea and retching, and endoscopy is almost normal, gastric emptying has not given us a result, this is where antroduodenal manometry is extremely useful to look at whether there is any evidence of change in the type of waves, whether you find any response to either octreotide or erythromycin, because as we know, octreotide can inhibit anything in the GI tract. It can inhibit all the juices. It can inhibit the contraction of the valves and everything. But the only thing that it accelerates is the phase 3 motility, which is also called as the housekeeper of the small bowel. That means the small bowel contracts so well that all the contents get moved on and the small bowel is cleaned. So this function is also important to clear substances. Otherwise, these patients tend to have phytodisorders or SIBO. So this is the one place where antroduodenal manometry is extremely useful. So the second question that you asked is, what is the prevalence of gastroparesis in refractory GERD? Well, the problem with refractory GERD is when patients keep on having volume reflux, we sometimes make the mistake of saying that this is GERD. Quite often, these patients primarily have a delayed gastric empty. So it's usually about 20%. Now, where is this important? It is important when you are going to subject the patient to a surgery for GERD. If we decide to do that, the first thing to do is take a good history, find out if the patient has bloat along with nausea. If a patient has predominant bloat, pain in abdomen, then this is not pure gastroesophageal reflux disease. And if by mistake some patient undergoes fundoplication, that patient will have hell because he cannot belch out. The stomach is bloated. The food is not moving ahead. It can't come out. And the patient really has severe bloat. So in any patient who is undergoing surgery for GERD, first of all, rule out gastroparesis. And how do we differentiate clinically? I just mentioned, if a patient has a history of bloat, abdominal pain, and nausea, keep in mind that this patient may either have additional gastroparesis or his primary diagnosis may be gastroparesis or delayed gastric empty. For all of us who are, endoscopists, there are some lessons which I learned during these times when I was trying to differentiate these patients. And what I found that if you take your endoscope and go deep into D3, D4, there are a few patients, you might even find an SMA obstructing the D3 and is responsible for the symptoms. So instead of labeling these patients as gastric motility disorder, at least do this much. You may not do a CT scan, but if you find that the lumen is compressed from the SMA, it's very important. And you can then give the patient treatment accordingly rather than sending them for GERD treatments or gastric emptying treatments. Coming to breath test, the role is limited right now because the specificity is not very high. And the last one about endoflip, I think only one center in India has the endoflip. It's extremely expensive. And both endoflip as well as EGG are useful when you are doing any interventions for gastric emptying rather than for primary diagnosis. Does that answer your questions, Dhaval?
Yes, ma'am. Yes,
Okay.
definitely. Thank you, ma'am. Madam will also give some inputs at the end of the discussion that will be discussed later on. Now, I would like to ask Dr. Swati ma'am regarding what is the actually for the general public who are not routinely doing, what is the gastric scintigraphy and how it is being done?
Yeah, gastric cytography is a non-invasive functional imaging of the gastric emptying. So in this, usually we do by solid or liquid meal, and usually solid meal is preferred because it is standardized. We have standardized protocols and reporting and everything. In 2008, there were proper standardization is given to for the comparison. So a comparison of reports can be possible. So we are doing routinely solid meal, and it is we are doing with the radio label idlis, because it is food is vegetarian. It is comfortable for our patients. Otherwise, in standardization, the egg white sandwich was given, but if for India, either roti or sabji or radioactive idlis are used. So we are using radioactive idlis, and we are using that premix idli one, and then we inject radioactive material, that is sulfur colloid. We cook around 2 idlis, 2 to 3, and then patient has to complete that in 10 minutes. After that, at 0, 1, 2, 3, and 4 hours, we take the counts, and that counts exactly give the percentage empty and according to that, we can say that it is delayed or not. So usually we are doing with the solid, and liquid sometimes we do, because some papers say that around 20 to 30% of patients have delayed liquid emptying when solid is normal. But we are still not getting referral for this liquid emptying. We have done few, and one patient we have found that solid was normal and liquid was delayed. So but there is no proper standardization for the liquid meal, and for liquid meal, because it is not like solid meal, it gives proper function, enteral, pyloric, and fundal. But for the liquid, it is very fast emptying, and only fundal contraction it can. I think liquid emptying only measures the fundal contractions. So if you are suspecting fundal dysmotility, then liquid meal can be given. So first is solid, and then if it is if you still suspected delayed gastric emptying, then liquid also can be done with the plain water. That is non-nutrient liquid, 300 ml water we give with the radioactive material, and it is a dynamic study of 30 minutes. So it is very fast. But separate day we have to do it, because the counts interfere. So first liquid or solid, or first solid, and then second day we can give we do liquid meal.
Both cannot be done on same day.
No, because that's the counts. Because we give some material, then some background counts also there. So, and solid meal, it is up to study. It takes almost 4 hours, and also prior 1 hour, because patient comes, then we give them food, then they have to finish the almost 5 hours study. So we cannot give, we cannot do study at the same day. It is a separate day.
Is this idli meal standardized?
Yeah, it is standardized in that Amrita Institute. They have done with the 100 and more than 100 patients, and they have a standardized amount that is around 2 or 3 idlis, 200 gram with 50 ml of water. And then they have standardized for the patients, normal and diabetic patients. So we have standard criteria for the idli meals. So we can use it, and we follow the idli meal protocol.
So Swati, just a quick question to you, if you don't mind. So is it that, these previous studies that are done in US and Europe, they talk about a low fat diet. So in this idlis, how much fat are you putting?
Is around slight more fat. It is around 8%. And that's egg, the low fat egg white sandwich is around 3%.
Yes.
So slight more fat is there. But they say if patient has symptoms due to some lipid rich food, then it is standard. But liquid is some fat is there, so we cannot avoid some fat content actually. So it is around 8% fat.
We are not adding extra fat. That's what I want.
No, we are not adding anything. We just put some water and that premix, and then radioactive material, and with idlis also they take water only. They don't take the food. So it is just that around 70% carbohydrate, 8% protein, and fat 8%. So it is low.
The last question, if you don't mind, the clinically, when do you want to ask us that we should ask for both solid and liquid gastric emptying? Because I don't know when to ask for liquid, so I always ask for solid gastric emptying.
Yeah, actually the liquid emptying, there are no standards papers actually. They have papers are available. They have done both solid and liquid, both together. But at our setup, it is not possible because 2 different radionuclides are required. One we have to indium, we have it is for liquid, and technetium, so we can image. But in papers, they say that if fundal dysmotility is suspected, because liquid is mainly by liquid emptying is mainly by fundal contraction. So if fundal dysmotility is suspected, we can add on liquid emptying study also. But it is first solid, and then after that liquid emptying.
Chirag mentioned that any premenopausal woman, the test should be performed in the first 10 days of the menstrual cycle. Is there any particular reason, or is it because to avoid the progesterone effect?
Yeah, it is because of the progesterone effect.
Okay.
That is because the hormonal induced mild delay. That is the main effect. Because the progesterone and oral OC pills also cause some delayed gastric emptying. So I think that is a reason.
Okay, thank you.
Okay. Thank you, Dr. Swati. I would like to ask Dr. Vismit Joshipura, what is the prevalence of gastroparesis in post-operative patient, and what is your approach in such patients?
Whenever the word gastroparesis comes, our first attention goes towards the post-Whipple's patients, pancreatic or duodenectomy patients, in which these delayed gastric emptying and post-operative gastroparesis are extensively studied and validated. The prevalence after the Whipple surgery, pancreatic or duodenectomy, is the literature has a wide range from around 5% to 30% of the patients, but it is of late it was observed that most of the patients are mixed up with the other complications of the pancreatic or duodenectomy, predominantly the leak of the pancreatic or jejunal anastomosis or pancreatic fistula. So if we consider only the pure gastroparesis after Whipple surgery, then the incidence comes down to around 8 to 10%, and that is called isolated gastroparesis. And so it is a relatively rarer complication of Whipple's as an isolated gastroparesis. The another surgery in which we fear for the gastroparesis is the fundoplication, because it is a commonly performed surgery and it is a surgery performed near the vagus, in which the literature quotes around incidence of around 4% to 14% of the patients they develop gastroparesis after fundoplication. All the gastroparesis, delayed gastric emptying was originally discussed extensively after the non-selective vagotomy, when it was done in the past for the refractory duodenal ulcers. And in those surgeries, obviously, the patients undergo some form of gastric drainage procedures. So, and those surgeries are also not performed commonly nowadays. So these are the two common surgeries. Other surgeries are any surgery performed on the pancreas, gastric conduits, even after transplants, it has been described. But the incidences are relatively rare.
Okay. And when will you do surgery in patients with gastroparesis, and what are the indications of actually surgery?
We are the last persons to come, and we would like to remain last, and even we would not like to come ever in this type of any physiological derangement to be corrected by surgery. Surgeries are predominantly for the defined pathologies, but for deranged physiologies, surgeries don't have any good results anywhere in the body, I feel. So when everything fails, surgeons come in the picture, and generally, if the so far I haven't done any surgery for only for gastroparesis, but no doubt the people have described laparoscopic pyloromyotomy and even subtotal gastrectomies for that. So if it is an end stage disease, then we come in the picture. No doubt, we can help out in couple of other things in other manner, that we can perform feeding jejunostomies, we can perform venting gastrostomies, and all those things can be performed just to maintain the nutrition of the patient. That can be performed as a surgeon. We can help out in that manner.
Yes. Okay. Okay. Thank you, Dr. Vishmit Bhai. I would like to ask Dr. Hiren Pat. He is the endocrinologist, as we all know. Is there any difference in the management of patients of diabetes with or without gastroparesis?
Basically, like as Dr. Chirag has already mentioned in his presentation, that these patients they tend to have wide fluctuation in their blood glucose levels. Because of delayed gastric emptying, the absorption of the carbohydrate metabolism is there is huge variation in the timing and absorption and everything. So that is why it leads to huge fluctuation. Plus, these patients they have nausea, vomiting, loss of appetite. So because of all these issues, these patients are very prone to develop hypoglycemias as well. and they don't tolerate because they are already suffering from gastric trouble, and some of the diabetic medications can also lead or aggravate this gastric problem. So they may not tolerate some medicines as well. Like metformin per se doesn't cause gastroparesis, but it can cause acidity and gastritis and everything. So these patients may not tolerate metformin, so we may have to stop in some patients. Then medicines like DPP4 inhibitor, GLP-1 receptor agonist, which are particularly acting on the incretin axis, GIP axis. And that these medicines, injections per se can also cause gastroparesis, or they can aggravate gastroparesis. So we may have to stop these medicines as well. Carbos also sometimes causes bloating and other the symptoms may get aggravated, so that we may have to stop that also. So it depends, like depending upon the condition, the symptoms, how severe are they, how is the patient tolerating the diabetic medicines. We may have to stop some medicine and we have to use some medicines which are tolerable to the patient, like maybe pioglitazone or sulfonylureas, or maybe SGLT2 inhibitor. And those patients particularly who are having severe symptoms, and we want a very good glycemic control, which we feel that it is not possible to achieve with medicines, then we may have to add insulin also. Because if patient is not tolerating metformin, DPP4 inhibitor, and we are left with very few groups of medicines to control the diabetes, then insulin comes in the picture. And even with insulin, there are issues. Like the newer insulins, short-acting insulins that we use, Lispro, Aspart, Glulysin, they are like that. Their onset of action is very fast, and these patients are having delayed gastric emptying. So the absorption of carbohydrate, the postprandial excursion of blood glucose level is little late. So because of this difference in the timing of insulin action and the carbohydrate absorption postprandial spike, this patient may develop hypoglycemia. So so what we do is that, like if patient is on short acting insulins, which are like the newer analogs, we may give the patient the insulin after food rather than before food, so that to match it a little bit, so that we try to match it with the physiology, that the patient is having a deranged physiology. And or the regular insulin, which is an older insulin, anyways it is a insulin which is having a little late onset of action, so that will also match the postprandial excursion in this patient where it is delayed. So these are the changes that we may have to do. Of course, diet also patient needs to do a lot of changes. So the management of this patient is definitely a little different compared to the other patients.
Yes. Okay. And do you find gastroparesis also in any other endocrine disorders apart from diabetes?
Yes, but not so common presentations of those disorders, because those problems anyways have a lot of other symptoms which can clinically pinpoint the diagnosis, and this is not a prominent symptom. But yes, it can happen with hypothyroidism, Addison's disease, and even some patients who are having electrolyte disturbances because of some endocrine metabolic problems like hypercalcemia, hypokalemia. But again, this is not a common or prominent symptom in those disorders.
Okay. Okay, doctor. Thank you, Dr. Hirenpal.
Yeah.
Now, I would like to ask Dr. Pratin Bhatt, when will you advise the endoscopic therapy in patients with the gastroparesis? Hello.
Your microphone is.
Pratin Bhai, switch on. Yes.
Nowadays, there are a lot of interest and encouragement for many minimal invasive and endoscopic therapies for gastroparesis. But basically, endoscopic management are made for refractory cases where medical management and dietary lifestyle is not useful or not have in spite of having this medication and diet modification, patient having persistent symptoms. And basically, most of the endoscopic intervention are aimed at the pyloric, on the theory of pyloric spasm. So we know that there are a lot of theories and there are a lot of pathophysiology of gastroparesis. So only targeting gastroparesis, targeting pyloric spasm is effective in only few patients. So only selective cases of refractory gastroparesis, have some role in of endoscopic therapies.
Okay. And what are the endoscopic options that will you use to treat the patients?
So there are initial case reports of balloon dilatation of pylorus, but it was not useful in nowadays. Only there are case reports only, and then people have tried botulinum injections and this G-poem. Even botulinum toxin, there is very well randomized control trial from Jan Tech group from Belgium that show that there is not effect. The botulinum toxin is not effective, and people have also tried this transpyloric stent placement, but it is also short-term use, and there is high risk of migration of stent. Approximately 60% of patients have migration of stent during this procedure. So these are all very selective patients have a benefit.
Okay. Is there any long-term data of G-poem and botulinum toxin injection?
Botulinum toxin, no, it is very rarely anybody use for gastroparesis. And as I told, there is a well-described randomized control trial showing there is no superiority when you compare with botulinum toxin with saline injection. They have given saline injection to a patient and botulinum toxin. There is no difference in even gastric emptying time. So botulinum toxin is not used. And for gastric poem, I think for idiopathic gastroparesis and for post-surgery gastroparesis patient have some role. For diabetic patient, in one of the study, it is negative predictor. And overall efficacy of the G-poem is around 60%.
Okay.
And there are a lot of now trials and research are going on the predictor to define the predictor of success of G-poem. So one of the marker nowadays are utilizes the flip. They try to use measure the distensibility of pylorus with endoflip. And that is a newer thing, and we should watch for this all new developments before trying any G-poem or any other endoscopic therapy for such patients, because efficacy is only around 60%, and most of the data are very short-term follow-up. Maximum follow-up is around 3 to 4 years.
Okay.
Because first G-poem was described by Moin Kashab in USA. That was in, I think, 2008 or 2010. And majority studies are from USA, where there is a lot of endoscopic therapies are done for gastroparesis.
Okay. Thank you, Dr. Pratin. Before we conclude and go ahead with the quiz, I would like to ask Dr. Sobhna ma'am to give some inputs on the common mistakes being done in the gastroparesis management and how to avoid them. So I would like to ask Dr. Sobhna ma'am.
Sorry. Dhaval, can you make me a co-host so I can share my slide?
Yes, ma'am. Yes, ma'am.
I have only 2 slides. Achha, I think you can just show it so I can use my slides. I'm more comfortable with them. There's nothing extra in them. Can I share my screen?
Yes, ma'am. Okay, I'm stop sharing. Yes.
Yes. Okay. So I'll share my screen. Where is that? Yeah. So we'll start from here. Can you see my screen?
Yes, ma'am.
Okay. So first thing, why I thought that I should be giving this after an extensive lecture by Chirag is more of a cautionary advice where, first of all, gastroparesis is something we're not really on firm ground with a lot of facts. First of all, diagnosis. The diagnosis of gastroparesis is something that's really, we talk about it, we say that it is easy to diagnose, but it's really not that easy. So any patient who comes with functional dyspepsia, who's not responding well, you do a gastric emptying study, 30% of them will have a delayed gastric emptying. And I think Dr. Swati would bear evidence to that a little change in gastric emptying is not what we are really looking at. So if we diagnose gastroparesis using incomplete evidence, we are going to treat it in the same way. And therefore, this is the first mistake in the diagnosis. The second is that just as gastroparesis mimics functional dyspepsia, we often don't keep that as a differential. We are so focused on gastroparesis that we don't look at other differentials. I already talked about SMA obstructing the D3, which can mimic gastric outlet obstruction. Sometimes we may miss a small lesion in the distal duodenum, and we may think that this is entirely gastroparesis. Quite often in youngsters especially, the students are taking cannabinoids and opiates. We forget to take these histories. So always ask for conditions before we put a label. The problem in any medical case is once you put a label, that patient carries the label and then nobody thinks of a differential diagnosis. The biopsychosocial factors, one of them is that whenever a patient is depressed, has not slept well, you find that there is a little change in the gastric motility, and therefore ask for such things that are happening. Maybe the patient is depressed, maybe they're taking drugs on the sly, especially drugs like escitalopram, which can cause a delay in gastric emptying and bloat, and we might be ignoring such evidences. Importantly, already Chirag has addressed this about nutritional issues. When we talk to patients, we think of, what can we do with these patients? We start thinking of doing gastric emptying studies. We think of doing, eventually we start thinking of whether we can do any intervention. But talking to the patient about their nutrition is one of the most important things. Telling them that they can develop deficiencies if they do not eat well. And what are they going to eat? They've got limited substances that we can eat because we cannot give them a high fiber diet. So they have to go on a low residue diet. Many of these patients are diabetics. So we have to sit with a nutritionist or a dietitian to plan their diet. And I think the diabetologist here or the endocrinologist here will definitely second this opinion. Now, if a patient continues to vomit despite giving them a pureed or a soft diet, then in that case, one of the options is to put in a jejunal tube and feed them before we start thinking of major interventions like surgery or endoscopic therapies. The other one is not optimizing medications. I think there was a significant discussion on that we don't give them the proper medications. Remember that an antiemetic like an ondansetron is not going to work as a prokinetic. Ondansetron slows down the GI tract. It does not accelerate emptying. So if a patient is vomiting, giving them ondansetron is actually a wrong choice. Give them something that will accelerate emptying, which is, say, a prokinetic like metoclopramide or a domperidone. Both metoclopramide and domperidone are the ones that are preferred because they are the dopamine antagonists. Levosulfuride in young women can cause severe hormonal imbalances, including change in their menstrual cycle, severe galactorrhea, so much so that some patients have been investigated to find out if they're pregnant when they are on levosulfuride. Of course, long-term neurological side effects are there. So I prefer to use levosulfuride only in men, and that too selectively. Long-term is just not on. The next is about the role of drugs in symptom generation. Opiates is just one of the drugs that gets talked about. But sometimes, as I said, patient is also on escitalopram. Patient is also taking NSAIDs for whatever reason, and they don't tell you about it. And we forget to ask. The next is overlooking the treatment of GERD. Now, when the patient has a delayed gastric emptying, they are bound to have reflux of gastric contents coming into the esophagus. At this point, because of the load of the acid that comes into the esophagus, they are more likely to develop complications of GERD, including grade D esophagitis or even peptic strictures. So these have to be dealt with according to whatever is the protocol for them, except that we can't do a surgery in them. So we have to treat them and continue high dose PPI, which is not the treatment for gastric emptying disorders, but GERD has to be taken as a separate step for them. Now, pain. Now, we mentioned earlier, Chirag mentioned in his talk that pain is one of the significant symptoms in patients with gastroparesis and can be a continuous severe pain. By speeding up gastric emptying, by giving them, say, drugs like any of the prokinetics, pain is not going to go away. Because pain has a different pathophysiology altogether. The pain treatment here is not painkillers also. What we need is drugs for visceral sensitivity. And that is where a little neuromotility treatment sitting with a psychiatrist can also help. Our endocrinologists on the panel have already talked about the diabetes control. But if we do not look at the diabetes control properly, the gastroparesis is not going to improve. The one thing we learned in physiology is that when the blood sugar crosses 300, I think 300 is the cutoff, the gastric motility is actually paralyzed. This can happen even in a normal individual. And this is what I understood when I was talking about diabetes control. So anything above that level, patients will start vomiting, bring the diabetes control, well, talk to an endocrinologist. This is something that a gastroenterologist should not be doing. Talk to the endocrinologist and see that the diabetes is controlled. Because as one of our previous speakers, like Hiren Pat said, that because carbohydrates are getting absorbed late, there's going to be a delayed insulin response as well. And lastly, Pratin already talked about this, is not selecting patients appropriately for the gastric intervention. If we do either gastric electrical stimulation or a GPOM or even a surgery, if the patient is not diagnosed completely as gastroparesis, we are wasting an interventional procedure and giving the patient the risk of side effects. As it is, the efficacy is only 50 to 60%. In addition to that, if the patient has even an 8 or 10% chance of side effects, it's not a good thing. We don't have a good face to show to the patient. So therefore, clear-cut diagnosis of gastroparesis with whatever modality we have, repeat the tests at 6 months if possible, because there are some studies to show that sometimes patients with gastroparesis may improve with your medical treatment and gastric emptying tests may come down to normal. And after 6 months, a functional dyspepsia may start looking like a gastric emptying delay. So this kind of thing happens in these patients. And therefore, repeat tests, maybe 6 months to a year apart, confirm that the patient definitely has gastroparesis, and only then and then subject the patient for any surgical intervention or endoscopic intervention. Medical treatment can be stopped, changed, modified. But once the patient goes for surgery, it's something that's permanent. So these are the messages that I had for all of you. And thank you for allowing me to give this message.
Just a short addition from surgeon side, that we have observed that some of the elderly patients with long-standing large hiatus hernia, or they come with gastric volvulus, we are called for the surgery. And when we do surgery, we found that almost half of the stomach is in the chest, and we take it down and repair and all those things. So we have learned from our mistakes, and then we have started adding feeding jejunostomy, prophylactic feeding jejunostomy in these patients, that these patients may later on go in gastroparesis after surgery. So we have started adding a prophylactic feeding jejunostomy. I don't have any scientific support for that, but for practical reasons, we have started this since last 3 to 4 years after burning our fingers in couple of patients after reducing large hiatus hernias.
I think
there is scientific support. During reviewing the literature for this talk, I came across a few surgical papers where they have said that the post-surgical gastroparesis in many of such patients is usually short-lasting and transient, and it is usually for 3 to 6 months, maybe because of some vagal nerve injury, which would recur with time. So it is absolutely justified putting a temporary feeding arrangement till then.
Absolutely.
Thank you.
That is, I'm going to add that as my 11th point, mistakes in gastroparesis, because that is a very useful thing that you have told us. Second thing, whenever there is a large hiatus hernia, especially when the fundus has gotten across the diaphragm and gone into the chest, sometimes there may be ischemic changes in the fundus, which may be responsible for the change in accommodation as well as emptying. And in those patients, I'm going to put it to you and ask you a bouncer question. Would you actually do something for increasing emptying? Like previously they used to do, I think, what was that? Pyloroplasty?
Pyloromyolysis.
Yes. I mean, whatever your, I'm sorry, my surgical knowledge is very poor. So,
So do I.
okay. So, anyway.
No, madam, it is very issue. Actually, we had not started any pyloromyotomy in such type of patients till now. But no doubt, when we use stomach as a conduit, after say we have operated CS esophagus and we use the stomach as conduit, we do go for the pyloromyolysis, which is just a crushing of the pyloric ring with the fingers without opening it, and that we do it for the CA esophagus when we operate the CA esophagus, but not for the such large hiatus hernia. But definitely we can include that process, that step in our surgery.
So with this, can we proceed to the quiz?
Yes.
I'll just stop sharing my screen. Yeah.
Okay. Thank you, madam, for this wonderful input. Yes. Now our quiz is on. You can join this by opening page kahoot.it on the browser or by downloading this app. And you will see one game pin number. You just have to enter that pin number and your quiz will automatically start.
Are you having any prizes? I think you should announce that.
Yes, ma'am.
You did announce there was a textbook. Yes.
Yes, ma'am. Yes.
Yes. Okay. Fine. So how many? Only one participant so far?
Hope there is no punishment for any missed answers.
No.
It's taking time.
I think this should have been told to them to download the Kahoot beforehand.
Yeah, I
Sometimes
think
they have a problem with that. Yeah. Yeah. Now people have started.
I think we can start.
Yeah, you can start.
Yeah. Yes.
Next time.
Yes. Here is the first question. Which of the following is not the cause of the gastroparesis? You just have to click on the right answer. Okay.
Don't show this. Yeah.
Which of the following is not a common symptom of the gastroparesis?
Thank God.
Okay. All of the following investigations are used for the diagnosis of gastroparesis, except. So, which one is not used for the diagnosis of gastroparesis?
Dhaval, you should take away your mouse from wherever it is.
Okay. Yes. In all of the following conditions, gastroparesis should be evaluated or excluded, except. Next question is, all of the following surgeries are a common cause of the post-surgical gastroparesis, except. Which of the following is the most appropriate diet for the patients with gastroparesis? In which of the following anti-diabetic medication may aggravate the symptoms of gastroparesis? Exenatide, saxagliptin, dapagliflozin, or glimepiride? All of the following medications are used in the treatment of gastroparesis, except. Okay. Now, diabetic gastroparesis with recurrent vomiting and weight loss and refractory to oral prokinetic and tricyclic antidepressant. What should be the next best option for this patient? Nasogastric tube feeding, nasojejunal tube feeding, PEG tube feeding, or a TPN? Which of the following endoscopic procedure is used for the management of the gastroparesis? GEPOM, endoscopic submucosal dissection, gastroduodenal metal stenting, submucosal tunnel endoscopic resection. Okay. Okay.
Yes.
We have to find out. We will contact and deliver his book on his address.
Yes.
Okay. Okay. Thank you all the participants. And on behalf of the Mission Gastro Hospital, I would like to thank all the esteemed panelists and all the audience for taking participation. And before we conclude, I would like to inform that we will continue our this lecture series every monthly, and our next series will be the on the GERD, the detail of which will be announced very soon. Dr. Chirag, would you like to give any conclusion remark?
No, thank you, everyone. Thank you, madam. Thank you, Navneet sir. I thank everyone for their esteemed presence and giving time to stay till the end of the meeting. Thank you.
Thank you. Thank you.
There should be a special prize for the surgeon.
Yes, definitely we will give.
A pure medical topic, and I am staying still here.
Yes.
We are the cause
You
of.
also came first in the first 3 ranks. That is the
Yes, madam.
Yeah.
I thought faculty should be debarred from appearing.
We are generally surgeons are the cause of gastroparesis rather than the treatment.
Absolutely.
Thank you.
Thank you, Chirag. Thank you very much.
Thank you, Chirag. Very well done.
Thank you, ma'am. Thank you.
Thank you.
Thank you.
Recording stopped.